and especially a company like Amazon that is customer obsessed. They actually mean it. Everything we do, everything we talk about, plan to do, starts with, is this better for the customer? So in our context, we ask the question, is this better for the patient? If it's not, then really there's no point in going to the next step.
Hello and welcome to Clinical Changemakers. Today on the show we have Dr. Raj Behal. He is a medical doctor and Chief Quality Officer at Amazon One Medical. Dr. Raj Behal, welcome to the podcast.
Thank you, Jenna. Pleasure to be here.
Now, you are the Chief Quality Officer at Amazon One Medical, and I think quality is really, really interesting. It means lots of different things to lots of different people, including clinicians. So I wondered, what does quality mean to you?
Great question to anchor with. I look at it from two different perspectives. One is how do we think about quality in the US? So you're familiar with the Institute of Medicine framing. Think about quality as 6 or 7 components. It's safe, it's timely, it's effective, it's efficient, it's equitable, and it's patient-centered. Just for convenience sake, I don't think of these domains as separate things. So if something is safe but it's not efficient, then it's not really quality. So I think of quality as, what is the patient? What is their job to be done? What are they trying to get out of? Whether it's this encounter or from their health, what are they trying to achieve? And making quality about that. So making sure we're offering a solution for those jobs to be done. Understanding, is it that they're looking to lose weight, or is it about self-esteem or wanting to live longer? So understanding that helps us tailor the solutions that actually meet their deeper needs, not just the superficial need. And having said that, one can't ignore, I would say, the table stakes measures. So the standard, what we call HEDIS measures, which are cancer screening, diabetes control, hypertension control, most of these are processes. Did we do the right thing or not? Did we control somebody's diabetes or their blood pressure if they're hypertensive? Yes or no? So they are important. But if you look at the overall quality that somebody wants out of their healthcare encounters, it's only a small sliver of that. So we're thinking hard about, are the patients actually better off? What is their quality of life? This notion of patient-reported outcomes, should we think about not just a visit with somebody who has menopause, but actually then measuring their menopause-related quality of life? So my notion is broader, and I'm happy to drill down into some of these concepts more.
I really appreciate that answer because it is a really hard question. And what I'm hearing in that is that there are some foundational principles that kind of undergird this, but individual patients have individual needs and desires. And I think as health practitioners, we are obligated to explore what those needs are, not just from our lens, but from our patient's lens. And then there's another piece here around the kind of population level understanding of what are the things that we really do understand can make an impact on people's life longevity as well as risk of hospitalization. And so there are elements where we have really strong footing to provide particular treatments, investigations, et cetera, and other areas where perhaps we can be more flexible and enable that unique patient journey to be fulfilled.
So you asked an important question, which is, to me, is one of the fundamentals. How do we think about quality? So in the US, and I'm sure in other countries, there are some standard national metrics that measure processes. So did we screen somebody for breast cancer or colon cancer? Did we control somebody's blood pressure or their diabetes? So these are, again, important metrics, but they only capture a sliver of what people actually want from their health and from their healthcare providers. So we think about, this, of course, as we must do, But then what else do people want? How do we measure what people actually care about? And those may be things like quality of life. They may be, formally patient-reported outcomes. So simply taking care of somebody with menopause, prescribing hormone therapy certainly is good care. But actually, if you can measure their menopause-related quality of life, it just makes the interaction and the measurement that much more meaningful.
That then allows you to have, a transparent conversation about what your goals are and where things are working and perhaps where things aren't working. And clinicians can then use that information to support treatment options, or perhaps the treatment, as you can see from scores, has sort of plateaued. And then actually going down the route of further pharmaceuticals may or may not be in this person's best interest. So it is a very complex space, which is multifaceted, that there are these foundational pieces of quality we do really understand, but it's then putting it into that patient's context and supporting that patient to make that collaborative decision. And obviously those decisions will change and morph with the relationship and the different scenarios that person goes through. I wanted to pick up on the question of measurement, because measurement in quality can be a really big challenge. There are lots of challenges on the kind of data aspect of having really high quality data that is meaningful and tangible, but also measures can be ways to misconstrue what's really going on for somebody. And I think there's a couple of sort of sayings I think we all use that can illustrate this around: not everything you measure matters, and not everything that matters you can measure. The other one is, when a measure becomes a target, it ceases to become meaningful. And there's another one, which is you can only manage what you measure. So these all are kind of in tension with each other. And I wonder what your take is on how you approach measurement in the healthcare space.
Yeah, I think there's a kernel of truth in each one of these constructs. Certainly, measuring what matters is paramount. There are many things that are measurable also matter. So that's where I start. What matters, and can we measure it? It's a different problem to figure out: how do we measure the unmeasurable? How do we develop proxies for things that matter? So part of this is a data science question that maybe I'll come back to. But we've been thinking hard about, how do we get even simple things noted? To give you a couple of examples, if somebody comes in to see me for low back pain, I might not have a quality metric for low back pain. But what our system does automatically is, as soon as I've completed my visit with the patient, 2 weeks from that date, it will automatically send a short question to the patient. Are you better? Are you worse? Are you the same? So we can measure that. Say, how often do patients leave? And within a defined amount of time, they're actually better. And if they say, well, actually, I'm worse, or about the same, then a member of the team will reach out and see, well, how do we help you? So this, again, is not an exotic measure. It's really simple. So often we look for things that are complicated, and we worry about risk adjustment, that my patients are sicker, they're different. But often you just need to measure, is somebody better or better off or not? Patient-reported outcomes, again, for primary care, there aren't a lot of these available. There's symptom scales. There's Epworth, the sleepiness scale. I mentioned the menopause quality of life. There are depression scales. There's diabetes distress scale. So we can look at these as a collective and use these in situations where it actually makes sense. So not measure for the sake of measuring, but really to understand, did we help this patient? Did we understand the burden of symptoms and their distress? So a different way of answering your question. So it's less about how do we develop new measures, It's more about how do we understand, and sometimes it's a conversation. And initially, I struggled with that. Okay, so it's a great conversation. Jonah, I saw you in clinic, and I understand what ails you and what you want to get out of that. And I make a note of that. But then I go back a month later, and I will look across the population and say, how many patients like you did I see, and what were the outcomes? So it's a bit dissatisfying that I can't say, oh, 70% of the time, patients like you leave happy and they're better off, that I actually met their needs. And it's okay to get comfortable that we can't measure everything. And sometimes this qualitative conversation is enough.
What I'm taking from that is it is not only the measurement in and of itself, it's the way that the measurement is implemented and the human connection and feedback to the purpose of that measurement. And so, typically in clinical spaces, we want to have, we want to collect all information and we'll send someone 20 questions and that'll give us, the most amount of detail. But it is the fastest way to get somebody to disconnect from you and from the health system. And so finding that sweet spot where you can get that kernel of information to then do an action, that the human side of things is always thought about how this is being implemented and supported.
I think it's paramount. Often we see policymakers wanting to add more metrics. There was a recent study that looked at how many metrics is a typical primary care provider accountable for. I think the number was ridiculous, it's in 50s or 60s. And as you alluded earlier, pretty quickly it loses all meaning. It becomes about the metric. We're trying to make the metric better, not the patients better. So I think we need a bit of a policy reset. I understand why these policies exist, but they need to be mindful. So we don't take away the intrinsic motivation of the clinicians, that I'm doing this to actually help you, not help my numbers.
At that higher level, rationalization, right? Because information changes, the sensitivity or specificity of one of these measures may have shifted. And actually, if you looked across the 50 or 100 or whatever it is, if you do your top 10 all the time in this cohort, you are doing the most for them. That is helpful and meaningful for clinicians to navigate and wade through the tsunami of measures that are asked upon them. And so perhaps there's a level of that sophistication that could enhance the uptake and the meaning for the clinicians. And that meaning can obviously be shared, right? If somebody's focusing in on a particular measure from a patient's point of view, and you're able to point out what that translates to into any kind of action or activities, that's going to help them buy in to participating or not.
And I think this is where I'm excited about newer technologies like generative AI and large language models. How do we make collection of quality data a passive activity that is done by the system for you? We've done some experiments with my data science team. Can we parse out quality and risk signals from unstructured clinical notes and from patient messages? So things like someone has anxiety, but they may not say, I'm anxious. It may be implied in their questions. Large language models are actually fairly good at picking those things up. So turning unstructured data into structured text that then could be analyzed. So this, I think, has the potential to change what we measure and, more importantly, how we measure.
With these experiments, I wonder, with large language models, my understanding is, depending on the model can really depend on how good it is. And so what I mean by that is in the healthcare, depending what the model has been trained on, really should inform what use you are putting it to work in. So how do you kind of navigate the exploratory, experimental side of things where you're trying to learn quickly versus finding the right fit and then pursuing that kind of angle?
Yeah, this whole notion of fitness of models, fitness for purpose, I think it hasn't gotten enough light. Certainly with Gen AI models, we talk a lot about bias and hallucinations, and there are ways to test for that. For non-Gen AI models, models tend to drift over time, tuned on a different population. You apply it in yours. We've read about a lot of these examples in the media over the past several years. The question is, how do we set up guardrails around use of these models so we can be confident that what is pulling out and what is putting out are actually rational and robust? We can get deeper into a technical conversation perhaps some other time, but I think it's really important that we think about, despite the excitement and the shininess of these new technologies, really think about, how do we assess robustness and safety and fitness for purpose of these models? And I know there are colleagues who are working on these. Chai is one of the groups that spent a lot of time thinking about, and my team is thinking about, how do we understand, for our purpose in primary care, what application of a Gen AI model to a problem means, and how do we measure the effectiveness of it?
Sort of shooting a little bit from the hip here. I think when you use these models just in a playful sense, how incredibly humanistic they sound and feel. And I feel like there's been a real rush to kind of deploy them with maybe technical guide rails, but not really operational guide rails. And what I mean by that is, perhaps there is a way to think about that deployment where it's much more an augmentation of the clinician that is supervised, not in a technical supervised sense, but more in a alongside the clinician. And you've seen that in some of the ambient voice to text type recording, but adding that extra layer of sophistication where there are perhaps suggestions or options that clinician and the patient can be utilizing that get some of that best out of the Gen AI, while also having that clinician quite tightly coupled into that scenario.
Human in the loop is one mechanism to make sure the output is at least clinically rational. But I'm tempted to go back about 20 years and talk about sort of my early lessons. So I have a postdoc fellowship in medical informatics, and I have a master's in public health, and I focused on clinical effectiveness. So, how do you translate evidence into care at the bedside or the chair side? And part of that was, how do you measure things and how do you risk adjust? So, after I finished my training, I looked at myself and said, okay, look, I'm an internal medicine doctor, trained in informatics, and trained in public health. What do I do with myself? And no one was looking for these skills. I found myself at a consortium of hospitals that did, among other things, collect data from all of the member hospitals. And these were largely complex, large teaching hospitals, academic medical centers. So my first job was to build risk adjustment models. And of course, there was nothing fancy, exotic. There weren't AI based models. It was simply logistic regression, technically still machine learning. So I spent a year building these models and then shared data on mortality with every hospital that participated in the consortium. And I fully expected that hospitals will start acting on these data, and they'll make changes, and I'll start to see reduction in mortality rates. And a year goes by and I see no change at all. And I finally reached out to one of the hospital CEOs and asked the question, say, look, your hospital's been at the bottom of the list for at least a year. What's going on? And why aren't people using the data? And he said, look, when we share these data, our clinicians, they say the usual is garbage in, garbage out. The models don't make any sense, etc. And it didn't take me long to realize that it's not enough to put data and models out in the field. You need some guidance, you need some coaching. You have to help people understand what these data are and what they aren't. And also make sure there aren't threatened by these ratings and rankings. So to make that long story short, I work with the chairs and medical directors and nurses and house staff in that hospital to understand what actually might be in their system that's driving the mortality rates. And of course, everybody knows it. And I simply packaged that in a report with some recommendations. They implemented those, and in less than a year, the mortality rates declined by roughly 20-25%. So a fairly sizable reduction. And then, we presented this nationally, and a lot of other hospitals started to ask the same question. How do we look at data systematically? So that lesson I've kept to heart. So the same applies to anything new we do with Gen AI. If it's a black box and it's making suggestions, is suggesting a diagnosis, most, at least senior clinicians, will not buy into that. So how do we help people understand what it is and what it's not? What needs supervision and what can be left alone? So I think lots of opportunities in the operations and making the workflows better, making data extraction easier. Less so, at least in this generation of models, to actually, make diagnoses and offer therapies.
That's a really helpful story. And I think it's really, really interesting around this idea that, to make change, to make effective change, it is still a human endeavor. Yes, you need to capture some data, you need to risk adjust, you need to highlight your assumptions, and but you need to then come to the table with open arms and open ears to discuss, debate, and argue over the data as one component, but then move forward as, okay, the data is what it is. What do we need to do here to progress this? And I think you made a couple of comments there around coaching. Coaching in clinical spaces is not that common. I wondered if you could tell me a bit more about what would it mean to do that kind of coaching?
It is first, personally, it's really gratifying to be able to help somebody see the same thing in a different light and not be threatened by it. As we started that conversation, metrics have become a thing that many clinicians are not keen to look at metrics because they know what comes next. They'll be asked questions, there might be incentives, there might be penalties. And this is how CMS, Medicare in the US, that's how they've approached this. So it's left a bad taste in people's mouth. So when I have these conversations with my colleagues, I help them understand, most importantly, what is it that we're trying to do? When it's quality data, we're actually trying to understand where do we have opportunities to do things better for our patients. That's the purpose. And if your metric rate is low and somebody else is high, I care less about that. I care about overall, how good are we in taking care of our patients? So once people understand what it's for and what it's not for, I'm not trying to set your salary based on how you perform on these metrics. Once people understand that they open the door. And now you help them understand, what is it actually measuring? And what are some of the things we might do to improve care? That's a different dialogue than your metric, your performance, and tell me, what are you going to do to improve this rate? So coaching first, then what do these data mean? And then what do you actually do about it? If it means changing your own practice, that's one thing. If it means changing your colleagues' practice, well, how do you go about doing that? How do you manage change among your colleagues? I worked with a surgeon at Stanford. He was really excited to work on, and I'll mention it because we published it, carpal tunnel surgery. He came to me and said, look, I think there are opportunities. We can make this much more efficient and probably less expensive. If I have some support, some data, some guidance on how do I look at processes and workflows, I want to do it, but I have no idea how to do it. So he spent a couple of months going back and forth, looking at data, looking at process workflows. And at the end, he came back with a modified workflow. And he said, look, there's some things we do that actually we don't need to do. There's some things we use that they're better, cheaper options. We worked on the project with some guidance, and he demonstrated about 30% reduction in cost for the procedure. And I was really impressed because we could have stopped and said, how do we engage the rest of the section, the department? Boy, that's a barrier. Don't know how to proceed. Said, why don't you do it for your own patients? And they said, yep, I have full control over that. So I think coaching is one of those older traditional skills that doesn't get enough attention these days.
And I'm hearing with that relationship that you had, some of this is also picking the battles where you have champions, you have people who are ready to change, who are eager to make those sorts of changes. And therefore, it means that exploring these areas is so much more effective. I wondered, when you approach those scenarios, how do you approach managing risk? So, for the example that you gave, perhaps one of those processes was, defined as a step that was supposed to reduce risk. And risk means different things to different people. It also means different things to patients. So often in healthcare, we're really good at adding things in, better to be safe than sorry. And we're really bad at pulling things out when we know the risk is there, but the likelihood is probably, perhaps it's low, and perhaps the harm is low as well. How do you kind of approach pulling things out of those sorts of processes?
Couple of tools. One is FMEA, failure modes and effects analysis. So anytime we do something new or modify a process, this is more from risk perspective. Do a failure modes and effects analysis to see what the failure modes are in any given process, what can go wrong and why and how bad might it be if it does go wrong, and can you catch it in time before it gets to the patient. So this is something that sort of made it my practice in prior life, looking at hospitals, higher risk processes. So that's a good mechanism to use to at least identify risk ahead of time, prospectively, and then mitigate that. And then you bring in a toolkit like the lean methodology, which sort of forces you to ask the question, okay, you're trying to achieve this for your medical unit, for your clinic, or for your patient. And these are all the things you're doing to get there. Now ask the question, does this step add any value to it? So I think that there are tools that are probably still underused in healthcare that have these forcing functions built in, that you pick every item and say, do I need it? If not, toss it. If you need something like that, you can say, hey, is there a better option? Is there a cheaper option? Is there a less expensive option, less risky option? So part of it is building these muscles in any healthcare organization. So you can look at your processes and your care delivery in a systematic way and figure out risk and also inefficiencies. Ideally upfront, but life isn't as simple. So you often end up doing this after the fact.
Now, I'd love to talk about your journey at One Medical. Obviously, there's been the acquisition of Iora Health and then being acquired by Amazon. I wondered, what is the One Medical model and what's the evolution been like?
So One Medical was started, I think, about 17 years ago now, with one clinic by a doctor who simply wanted to make care better for his patients. Tom Lee was the founder. If I fast forward rapidly to what is the model, One Medical model, it's probably one of the better combinations, blends of in-person care, virtual care that's available 24/7, and digital health. Blending it together in a way that our patients feel free to use what's going to work best for them. Want to make getting care easier for more people. All of our providers are salaried, which is not the norm in the US. Uh, they're not incentivized to do more, see more, and therefore get paid more. So that helps us keep an even keel when it comes to value-based care. Appointments are longer, 30 minutes. I practiced in other systems where I'm churning through patients in 12, 15 minutes. And I might have 3 patients booked in the same slot, running from room to room. So interestingly, this is what sold me on One Medical. There's one observation 7 years ago when I started. So I was simply exploring. I didn't know anything about One Medical other than it's a primary care group. And there are many clinics in the SF area and New York. I rounded with one of the physicians whom I'd known from Chicago. And as he's showing me around, he looks at his watch and he said, "Oh, I have to go." In the middle of the conversation, he said, "I have to go. I have a patient in 1 minute." And I'm thinking, yeah, 1 minute. You could be 5 minutes late. But he said, "No, 9 a.m. means 9 a.m. We start on time." And I thought about that later. But in the moment, I said, "Wait a minute. And you can do that?" And he said, "Yes. We do it every single day, every single appointment." And I'm thinking, boy, if they can do that, imagine what else they can do. That's probably one of the hardest things to do, starting appointments on time and not keeping patients waiting in a waiting room for 30, 45 minutes. So just based on that one observation, I said, this may be a place for me. I've been thinking about, going upstream in primary care. I was taking care of sick, complex patients and thinking if they had better primary care 5 years ago, 10 years ago, they wouldn't be in this situation. They wouldn't be listed for a liver transplant. That's a consequence of fatty liver that happened 10 years ago. Those some of the features of the model that again seem simple, starting appointments on time. And by the way, I realized that it took me a few years to get that through my head, that the reason One Medical did that wasn't to be efficient. It wasn't SLAs, service line agreements. It was really respect for patients' time. That you're taking time to come see me at 9 a.m., I'm going to respect that. And I'll see you at 9. So that model really resonated. To be honest, I didn't think I could do it, start appointments on time, but somehow magically, you plug into this system and you do it. So if I'm running a minute late, I find myself apologizing. "Sorry to keep you waiting." And most patients say, "Wait a minute, I just got here." But I say, "Look, it's 9:01. I'm late." So it's really patient-centered, human-centered model. We care about the doctors and the clinicians' work-life balance. And we care a lot about, are the patients getting what they need from us? So a lot of this has to be built into the model. So that just answers the first part of your question. That's the model of One Medical. And I think it was 2 or 3 years ago when we acquired IORA, which is a group, medical group like us, culturally fairly similar, that focused on older adults, 65 and older, in Medicare plans or federally funded plans. So we went through integrations, again, a lot of lessons learned. And then you fast forward, and now we're integrating into a much larger, a much longer established culture. It's really exciting, right? In healthcare, you don't get to see how are successful companies run efficiently. And especially a company like Amazon that is customer obsessed. They actually mean it. Everything we do, everything we talk about, plan to do, starts with, is this better for the customer? So in our context, we ask the question, is this better for the patient? If it's not, then really there's no point in going to the next step.
I mean, it sounds like a really interesting place to be. And I imagine your role in the quality space is really vital, right? Because we know that providing high quality care can, reduce hospitalizations and mortality and all those things, but it doesn't always translate to what a patient perceives as high quality care. And particularly in some areas where people focus on the kind of consumption of healthcare and feeling that that is what good care looks like, I think it's so important for clinicians to have that relationship where we can support people to make sure that they're always getting high value care and not low value care.
There are three things I think about to frame the work we do. First is that healthcare has a three-body problem. And I'm not referring to the TV show or the celestial mechanics of Earth, sun, and the moon. The three bodies in this context: the patient, the provider, and the payers. So oftentimes we optimize something for one, but it doesn't work for the other. So 2 out of 3 is not good enough. So it's a constant reminder when we think about whether it's quality or safety or value-based care or efficiency, that we're trying to solve this three-body problem in healthcare. So always be mindful, does it work for the three? If it doesn't, there's a flaw someplace, and maybe we don't have the answer today to make it work for all three, but it's something we need to iterate on. The second thing I remind myself is what I call the reservoir. A lot of attention, the whole US healthcare system is tuned to the sick and the complex. So, of course, we have to take care of patients who are sick, chronic conditions. We have to be really effective and efficient to making sure we control the condition and prevent its sequelae, but not enough attention on the reservoir, which is the source. This is where chronic conditions come from and high costs comes from. So we have to tap this reservoir. And conditions like prediabetes, overweight, tobacco use, physical inactivity, a lot of these social determinants, they all sort of live in the reservoir. There may not be a good payment model for it, especially not in a fee-for-service model that's most prevalent in the US, but it's something a system like us, we feel we have a responsibility to think about. How do we do this better? How do we learn? And then how do we share this with others? That there is a way to sort of stop this assembly line. So we're taking care of patients here, but they keep coming. So, and the third is more a reflection on what's happening in the industry. Healthcare industry seems to be focused on building a faster horse. If you recall his reference to Henry Ford, I think somebody asked him, why don't you ask the customers what they wanted? And they say, if I asked them, they would say, I want a faster horse, but I give you a car. So there's a lot of focus on how do we make it more efficient? And oftentimes that sort of falls on providers. Raj, can you see more patients? Chona, can you see double your panel size? Can you work weekends? Can you work nights? Right? Like, okay, this certainly goes back to the three body. It might actually work for the patient because there's much more access, right? I can be available 24/7, but that to me is a faster horse. It's probably not what the patient wants. It certainly doesn't work for me as the provider. So how do we think about the system, the design differently? How do we think about optimizing the care model and ask the question, hey, do I need to do this? Does a nurse need to do this? Or can a machine do it? So I'm hyper-focused on this notion of routine cancer screening and routine testing. Why do I have to do it? Why do I have to go click, click, click and order an A1C for a patient or a mammogram or routine cancer screening? Why can't a machine do it? So I think we need to think about the model of delivery differently, not put everything on humans. Think of maybe Gen AI as a new member of your team. And his job is to take all the important but grunt work and do it for you and do it much more efficiently. If it takes me 12 clicks to order something, it's 12 fewer clicks that I need to make if the machine can do it. Personally, I think about 80% of these routine testing screenings can be ordered by a machine. So it will start to destack the work of the PCP, of the GP. If we apply care redesign first and then apply newer technologies.
There are some standard journeys for all of us in either screening or other types of care where there is a reasonable cascade of events that occur once you hit a certain gate, and that actually surfacing that to patients in a supported manner can help facilitate some of this self-selection as well, that empowers the patients, offloads some of the work, and perhaps the clinician's role is more of a monitoring, supervising. If somebody hops off the happy path, they get that additional intervention. Now, you've also got this ambitious goal around heart disease. I wondered if you could tell me a bit about what you're thinking there.
Yeah, so this is something I've been noodling on for a number of years, looking at the data on both prevalence of chronic conditions and also looking at the leading causes of death in the US. And heart disease has been number one ever since I finished training. So been wondering about, well, heart disease is, I would say, largely preventable. So we know the clinical signs. We don't yet have the implementation size. But what if we took that as a goal? And this is still at the what if stage. What if we took that as a goal that will dislodge heart disease as the number one cause of death in the country, and not at the expense of other conditions that will just take its place? But how do we prevent heart disease? How do we detect subclinical atherosclerosis early, timely, in more people? And then start to offer lifestyle modification and those who need medications. How do we start this process early? Detect disease early, treat early, timely, effectively. All of this can be done. There's nothing earth-shattering, groundbreaking in the clinical side. What's difficult is some of the inertia that's just built into our systems and the friction that a lot of patients face when they need to access care, when they need to get testing. So a calcium score, CT scan, getting that in the US, it could take a month. You might have to pay for that out of your pocket. So how do we mitigate some of these pain points? Design a new workflow that helps us get from point A to point whatever, so we can start to at least show we're reducing the risk. Someone who starts in the highest risk category for ASCVD, 10-year risk of dying from heart attack or stroke, how do we bring them down? How do we bring them lower? How do we keep those who start at the low risk side in the low risk category? So we think about these as a mechanism or document is called a PRFAQ. Essentially, you write a press release dated 5 years or 10 years from now, where you pretend you're announcing that, hey, we've solved this problem. And then you work back and say, okay, what would it actually take to solve this problem? What do we need to do? What do our partners need to do? What would patients need to do? What would providers and payers need to do? So again, back to the three-body problem and the reservoir. So we have to figure out how do we connect that. And I'm not suggesting we've solved the problem, but this is what I do clinically in my own practice. I see patients and I work hard to surface any latent risk, whether it's family history or the lipid panel or LP little a. There are a lot of things that are available, but we haven't implemented those yet. So I would love for healthcare organizations to band together and say, well, how do we do this together? You know, it's not something that one medical needs to do by itself. I'm not looking for a trophy at the end. I'm just looking for better ways, more effective ways to do this and to be able to spread and scale this. And I think that's part of the work ahead of us.
When you look at this problem with your public health background as well, how do you see where maybe there's a line or maybe there isn't a line in terms of some of the sort of social determinants of health in these sorts of spaces, how people can access nutritional food, get around their neighborhoods to exercise, those sorts of things that perhaps sit at a policy level?
That is probably the hardest question that we face, right? That we know there are food deserts. It's easier to get fast food and cheaper than to get a bunch of vegetables and fruit. So at policy level, I think this is not a federal policy issue. I think this is what states and local jurisdictions have to figure out. A lot of these problems are local. So how do you provide access to food, whether it's available locally or is delivered to you? Beyond that, I don't have an answer. We know it's a need, and we need to, put our heads together to figure out how do we solve this part of the equation. And that's my point about the, documents like PRFAQ. They force you to ask and answer questions like that. So how do you get better nutrition to individuals that might be at high risk for heart disease?
It's a challenging problem. I think you have quite a unique advantage in your relationship with Amazon and other sorts of experiences, perhaps where some of those resources and kind of infrastructure that already exists, perhaps is a exciting leverage point.
Every country, every state, every city has a post office. What does post office do? Deliver stuff. So could creatives at the policy level get together and ask the question, how do we leverage what's already there in every community to get, in this example, fresh vegetables or fruit to people?
All right. Well, Raj, this has been an exciting and really fun walk through your career and current role at One Medical. So I just want to say a big thank you for your time today. And if you had any advice or books or anything at all that you think maybe health professionals can pick up to get a better glimpse into the quality space, I'll be all ears.
And thank you. It's my pleasure to join. We're grateful to be invited and share what little I know about this space. And I'm happy to share some resources and, books, etc., that I found useful.
Brilliant. Well, I'll link those into the show notes. So we might leave it there. Thanks so much for your time.
All right. Thank you.
And that brings us to the end of the podcast. If you want to go deeper about any of these topics or join in on the discussion, visit our website, clinicalchangemakers.com, or our YouTube channel. Finally, if you enjoyed our work, please give us a rating and share your favorite episode with a friend or colleague. Until next time, take care.